Why don't we go ahead and get started? So, good evening, everybody. I am so excited you are here for our fall kickstart of In the Know. Once again, we had a couple months off, but we're back at it and really excited to share some great information. I'm Dr. Britta Ryerson. I'm a new physician to the team, joining as our Midwest and Central Region Medical Director, currently located in Minnesota, where I am seeing patients virtually. And I am just so thrilled to be able to introduce our topic and our speaker here tonight, because the topic is very near and dear to me as well as to many of you: menopause and midlife metabolic wellness. Where do we go from here?
You know,
Katelin Cashman is our wonderful physician assistant in Needham, and she is our local expert in everything menopause. And she has put together a great presentation for us all. So without further ado, I'd love to kick it over to you. Now, keep in mind, if you have any questions, there is a Q&A box. So type away. I'll be moderating those. And in the end, we'll come back together and be able to answer all the questions that we can get to. So, Katelin,
thank you, Britta.
following
So,
you.
hi, ladies and men. If you guys roped anyone else into the presentation, I'm so happy to be here tonight. I really can't tell you how much joy it brings me to be able to have this forum where I can present some information with you that helps lay the framework for how I help women at midlife with their concerns related to their weight and their metabolic health, and how we can use tools that are safe and effective, like hormone therapy, that might help on the journey. I want to just uh, preface this by saying we have a really small amount of time together, and I have way too much information for me to present it to you all in one sitting. So if there's a lot of interest, I'm happy to do more sessions like this if there are other areas that we really want to explore. But tonight's focus, as Britta mentioned, is really on metabolic health and how that can be a challenge for women at midlife. So I think we should probably just dive right into it. And you guys should thank Britta, because I took about like 50 slides out of this presentation to simplify it and leave more time for Q&A at the end. So I'm excited to get right to it, and then we'll answer your questions going on. But I'm going to share my screen, and hopefully this is seamless here. All right. So Britta, feel free to send me a message if for some reason my audio or video is not going, but I'm going to assume that you guys can all see and hear, and we'll get started. So thank you so much for coming again. A little bit about me to understand my lens and how I got to this point here. I am a longtime primary care provider, internal medicine provider, and about 4 or 5 years ago, I started to focus my expertise in obesity medicine. And on the way, I was seeing lots and lots of patients coming in with similar concerns. And I said, I feel like my toolbox is missing something. So I took the opportunity to explore further education in the field of menopause. And these fancy letters after my name say that I have a certification from the Menopause Society to help women at midlife and beyond with things like hormone therapy. And those other fancy letters after my name say that I'm someone who took additional courses in nutrition as a wannabe nutritionist, but I know my scope of practice, and I am not. We have some of our nutritionists tuning in tonight from knownwell. So when I have other things that need, further expertise, you'll of course be recommended to see them. Okay, so without further ado, here we go. And I have a few objectives tonight. I'd want to just start with some basic facts to lay the groundwork here, and then we'll explain some signs and symptoms to look out for and the impact of perimenopause and menopause specifically on metabolic health. And with our short time together tonight, I've narrowed that down to specifically obesity and diabetes or prediabetes, or a precursor to that, which is insulin resistance. And then finally, at the end, we'll talk a bit about hormone therapy and why that might be helpful. Okay, so I'm gonna throw out some facts there, and shocker, women are half of the world's population. And when you think about it, menopause is something that is going to affect all women who live long enough. So you've caught my attention here because, spoiler alert, full disclosure, I'm a premenopausal woman, but at some point I'm going to be a menopausal woman. So let's all tune in because this is either affecting you now or going to affect you or someone you love in the near future. And this is the largest growing demographic group right now of women, right? So picture 5 or so years from now in 2030, 1 to 1.2 billion women worldwide will have entered or be entering menopause. And in the US, the average age of that is 51. And the average age of perimenopause, which is that transitional time between someone who's premenopausal and menopausal, that's somewhere around 45. And then at that same time, by 2030, the CDC estimates that 1 in 2 adults will have obesity. So, we are going to see a huge increase in women who are experiencing concerns at midlife related to their weight. And our goal is to keep you healthy enough so you're going to spend the next 50 years of your life in menopause. And we want to make sure that we're addressing those signs and symptoms because untreated women have more doctor's visits. They increase the cost of healthcare. They're missing work. They're retiring early, right? So it's really important that we narrow our interest. And I want to start by just talking about some really basic physiology here. And I can really geek out on stuff. So forgive me if I seem very excited about explaining physiology or research to you. But essentially, we're talking about hormones when we talk about menopause. And the hormone I really want to, shine the spotlight on is estrogen here. Yes, progesterone, yes, testosterone are other important hormones that all humans are, managing. But for this focus and for medication intervention, we're going to focus on estrogen. So estrogen is the primary female sex hormone, which is a bit of a misnomer because this hormone doesn't just impact your reproductive organs. This is really a hormone that affects you head to toe. And the purpose of estrogen is that it's a messenger, right? So it's made in one location, and then it crosses a long distance to create an effect in a target cell or a tissue. It's like the Wi-Fi in your home. So we know that all sex hormones are derived from cholesterol, which I think is really important because cholesterol gets a bad rep. And it's important to realize that cholesterol is good. And I think it's also important to realize that if you peek here and you look at this fancy little chart I have, you'll see that testosterone is the precursor to all estrogens, right? Estradiol in particular. Because when we're talking about estrogen, there's actually 3 different kinds of estrogen. And the one that is really applicable here is we're talking about women going through menopause is this estradiol, which is the kind that's most dominant in premenopausal, non-pregnant women made in the ovaries. There are other kinds of estrogen that are important at other points in your life, whether you're pregnant or postmenopausal, when either the placenta takes over or the majority of your estrogen in a postmenopausal woman is made in adipose tissue. Adipose tissue is our fat tissue. So we know that estrogen and other hormones are regulated by this really neat relationship between the brain and the organ that's making the hormone. And we've only known about hormones since the 1920s or the 1930s. So I think it's, kind of amazing that this seems like a really obvious conversation we're having right now, although it wasn't always one. And I also want to, highlight the fact that estrogen, testosterone, progesterone, these are human hormones, right? And it's not just a female hormone, but postmenopausal women, when their ovaries stop making estrogen, have either equal or lower levels of estrogen than their male counterpart, right? So this is a major cosmic shift for a woman. And I've mentioned that estrogen binds to receptors. So where are those receptors? They're everywhere, right? We're talking head to toe. Nearly every tissue and cell type in the body has hormone receptors. Again, we're shining the spotlight here on estrogen. But this neat little chart here is kind of an overview of the different organs in the body and where estrogen can bind to and the effect that it might have there. I've also taken a moment to find this really neat picture of the brain that's showing how the brain is so rich in hormone receptors, estrogen receptors. And when you think about the functions of estrogen, depending on what tissue it targets, it's going to create a different effect. And these effects lead to sexual development of, things like breasts, for example, vasodilatation, meaning it opens your arteries. Estrogen is anti-inflammatory. It's immunoprotective. It works with your blood coagulation. It works with your cholesterol and your sugar metabolism. It's neuroprotective. It has a big role in the brain. So you can imagine this like major change that a female experiences when she's no longer having estrogen bind consistently to these tissues. Even the brain alone, if you look at all those estrogen receptors in that frontal cortex, we're talking about, changes in your executive functioning. This is your decision making, your working memory, your emotions, your attention span, right? So to call this a sex hormone is really doing it a disservice to how important it is for the whole female body. Okay, so now that we know that estrogen is kind of the hormone behind the change that leads to menopause, let's just lay out the timeline here so we can all be on the same page about what menopause even is. So when we think about this change in your estradiol production, you should really think of it in like 3 phases. We have perimenopause, menopause, and then postmenopause. So perimenopause is the first thing that women experience. In the US, it's usually around like 45 and could be anywhere from 45 to 50. And perimenopause lasts years. And it's this transition between a premenopausal woman and menopause where you stop making estrogen consistently. Menopause is often a diagnosis made in hindsight, right? Because wouldn't it be lovely to wake up and know that the period you were having was your final menstrual period? For most women, it's a diagnosis that we make after when we say, wow, it's been 12 months since the final menstrual period, and there's no other explanation to say why our periods are stopping. We can further differentiate menopause into stratify it based by premature, early, or typical onset. So that's why I have this nifty little chart down here. So premature menopause would be someone who's has ovarian function stop before 40. Early menopause is someone whose ovarian function stops between 40 and 45. And then average menopause could be, in the US, like we said, it's 51, but all the way up to 55 is considered normal. And it's important to realize that the earlier a woman goes through menopause, the more likely she is to have not only signs or symptoms related to, conditions that happen in menopause, but also more health risks later in life. And finally, postmenopause is what most of us are talking about, right? That's the 12 months after the final menstrual period, but that's where a woman stays for the rest of her life. So the next slide I have here is this representation of what hormone activity looks like depending on if you're premenopausal, perimenopausal, or postmenopausal. So in premenopause, we can see these ups and downs, these peaks and dips here, and the different colors represent, either hormones or the messages from the brain that give that feedback loop that tell the ovaries how to behave. So in premenopause, we have this beautifully orchestrated, cycle here that leads to menstrual cycles. And then you wake up and it's your 45th birthday and you're like, holy cow, what is happening to me? You're not making it up, right? Look what's happening in perimenopause. This is chaos. We see these wild fluctuations in hormone levels, and they can vary like minute to minute, week to week. So this is why a woman feels like she's going crazy because her hormones are going crazy. And this is a really particularly hard time for a woman to manage her symptoms because not only is she at times having this inconsistent ovarian firing, she's still potentially at risk for pregnancy. So we still have to even think about that. And then somewhere on the journey between perimenopause and postmenopause, you have that magical menopause where you get to look back and say, oh, it's been a year since I've stopped menstruating. And then postmenopausal women, it's pretty easy to predict what their hormone levels are going to be because we have consistently low ovarian made hormones like estrogen and progesterone and consistently high brain signals of FSH and LH. Okay, so remember that chart where it showed everything going haywire? Well, this is why 75 to 80% of women are symptomatic during the change from perimenopause to menopause. And I know this is a busy slide, but that's because it's a busy time. And I wanted to validate all the signs and symptoms that women are experiencing, even if they feel wonky, right? It's because again, those hormone receptors are on nearly every tissue type in your body. So what I've done on this chart is I've highlighted in red the only indications right now that are FDA approved for hormone therapy. We'll talk about that in a few moments, but I just wanted to validate the other things that are going on during this time. So why am I spending so much time talking about this? And why am I wearing a Barbie pink vest? Because I'm promoting women's health and awareness and validating you. Because menopause is more than just a hot flash. I do need to clarify that menopause is not a disease, and menopause itself doesn't cause illness, but the hormonal changes that occur lead to tissue remodeling, and that tissue remodeling leads to symptoms, and those symptoms can lead to health risks. So when estrogen is not consistently binding to that target tissue and that remodeling occurs, that's when we have these major, I think of like 5 major buckets of health risks. The first is cardiovascular disease. And I know that's not what this presentation is about, but I would be doing you a disservice if I didn't pause here real quick and just have this huge public service announcement that the leading cause of death in postmenopausal women is cardiovascular disease. That's heart attacks, strokes. And more women are dying from cardiovascular disease than from the next 5 causes of death combined, which includes cancer and breast cancer. And there's a 4 times increased risk for cardiovascular disease in women in the 10 years after menopause. So it is really important that we're talking about this, because not only do we want to improve your quality of life, but we want to improve your how long you're going to live, literally. Vascular disease. Then we have frailty. Frailty is low muscle mass, osteoporosis, breaking bones. We have cognitive disease. That's neurodegenerative disease like dementia, Alzheimer's. But I also want to include in that mood disorders like depression, anxiety. We have sexual health concerns. I think that, sex is not extra. I think sex is a part of every woman's, every human right. So I think that's an important thing to acknowledge, although I can't carve out the time for that in this presentation. What I am going to focus on is that 5th bucket, which is metabolic disease. And I think it's really important to remember that we don't practice medicine in a vacuum. I don't treat one problem. I'm not treating menopause. I'm not treating hot flashes. So when I see someone and I'm helping them with their metabolic health, which is when they see me for, weight management or, control of their diabetes or their cholesterol, it was an interesting finding came out of the Framingham heart study, that showed that obesity raises the risk of coronary artery disease by 64%. And obesity and cardiovascular risk that impacts us differently than our counterparts. Okay, so let's get to the meat of it, right? I know this is why a lot of you are here today. Well, what in the world is going on in menopause and why am I gaining weight? So validation, you're not making it up. 60 to 70% of middle-aged women experience weight gain. And we're not just talking about an overall weight gain, right? We're really focusing on abdominal obesity. So this is the increase in your waistline that's happening. And this increase in your waistline is 5 times greater in women at menopause than before they went from menopause. So something is obviously shifting. I want to just highlight that the average weight gain during midlife and the menopause transition isn't as much as you would think. It's about 1.5 pounds per year, but it's really this increase in your waistline that's making a difference. So when I think about the factors that are leading to weight gain, I can think of 3 main things that are happening to women at midlife. The first is reduced muscle mass, right? So when you get this increase in your fat to lean ratio, what that means is you're reducing your skeletal muscle mass, which is one of the driving forces that helps, predict your metabolism. I'm also seeing that your metabolism goes down in general, like up to 250 to maybe 300 calories a day. That's a big difference. And then finally, we're seeing that shifting of fat storage to your midline, where you're no longer maybe a pear-shaped person and more of like an apple-shaped person. And this is a big deal because that leads to increased risk of metabolic disease when you have weight around your midsection. And what's going on in menopause to cause diabetes? Because we know that there's a 10 to 15% chance of developing a new onset of type 2 diabetes at menopause. And as I mentioned before, the timing of your menopause is really important. Women who go through menopause earlier are more likely to develop diabetes, than women who go through menopause later. And what's happening there? Well, we know that number one, the pancreas cells just don't work as well as they used to. So you have reduced insulin secretion, and you also have increased gluconeogenesis. And that's a fancy term for describing the body's ability to make glucose from non-carbohydrate sources. So maybe this is why that woman in her 20s or 30s did really great on a low carb diet. And then all of a sudden, when she tried it again in menopause, it didn't work as well for her. And finally, we also see reduced insulin sensitivity, or on the flip side to that, insulin resistance, which we know means that you just are not using the insulin that you're making very well. You need more and more insulin over time to control those blood sugar numbers. And eventually, we not only see the pancreas burn out, but all that insulin does promote weight gain. Oh my gosh, this was all so depressing. So is there any good news? And the answer is yes. There's been plenty of research that shows that estrogen is protective against these changes and metabolic disease from occurring at midlife. And the effect is not just on our adiposity, our fat tissue, but the effect goes from your brain to your liver, to your pancreas, to your muscle. So all these wonderful changes can happen if someone, has estrogen replacement. Well, wouldn't that just make sense to give everybody estrogen? Why aren't we doing this? Why isn't it like, a standard of care? Someone wakes up and they're 45 and you give them estrogen so they don't get diabetes. I know that makes a lot of sense, but even, anything in medicine is always a risk benefit, right? And hormone therapy, which would be something like estrogen replacement, has been FDA approved for 4 reasons. Hot flashes, genitourinary syndrome of menopause, the prevention of osteoporosis, not the treatment of osteoporosis, or someone who goes through early or premature menopause. Okay, so wait, nothing in there says weight loss, prevention of diabetes, muscle growth, dementia prevention, preventing heart attacks, et cetera, et cetera, et cetera. I know. That's because it's not FDA approved for those things. It doesn't mean you can't, recommend hormone therapy for the right person in an off-label use. Off-label doesn't necessarily mean that it's a problem. It can still be safe and effective. And in particular, I've highlighted hot flashes and night sweats because we know that women with obesity are more likely to have hot flashes, and women with severe hot flashes are more likely to have more severe obesity. So there's certainly a correlation there. And we've seen that even losing a modest amount of weight, like 5 kilograms or like 10 pounds or so, may really improve the tolerability of those hot flashes. Okay, well, what do we do with hormone therapy? You told me that it might work to help, prevent some of those midlife changes. Well, when you look at women who use hormone therapy for obesity, you'll notice that they get a reduced abdominal weight gain. So their waist circumference might not increase much. The overall weight gain effect that will maybe reduce on hormone therapy is kind of a small effect. But certainly might help improve that increase in your waistline. It can reduce the new onset of type 2 diabetes by 15 to 30%, depending on what meta-analysis or report you look at, which is really amazing. And it can improve your cholesterol parameters. Basically, all the bad stuff gets better. So these are just some of the many ways that hormone therapy may help you in an off-label way for someone who has concerns with their metabolic health. And even though it's not FDA approved now, we know that research is starting to back up the fact that adding hormone therapy might be helpful for weight loss. And I would like to take a minute here and just share with you some new research. This was an article that was published in the journal Menopause back in the April of 2024 edition. And the purpose of this research was to monitor the weight loss response to patients on semaglutide, Wegovy, in postmenopausal women who are either taking hormone therapy or not. And spoiler alert, it worked. It worked pretty darn good, right? So if you look at this little graph here, this little chart, the percentage of postmenopausal women who are on Wegovy, who lost greater than or equal to 10% of their total body weight at 12 months, so this was after a year of therapy, using hormone therapy was much higher. It was 77.4% compared to women not using hormone therapy when it was 58%. Side note, that's still a pretty darn good outcome for people using, Wegovy to help them achieve a significant weight loss, but maybe it's a little better when we add hormone therapy. And if you look at this chart, I know it's a bit busy, but basically the dark blue is the patients who used hormone therapy. The light blue is the patients who didn't use hormone therapy. And you can see these charts. This is the total weight loss. This is the time. It's pretty easy to see that patients who used hormone therapy did better than patients who didn't. The ones on the top, A and B, those pictures represent people who use semaglutide at lower doses, like between 0.25 to 1. And the ones on the bottom are the patients who were using semaglutide at the continuing doses, the 1.7 or the 2.4, which had arguably a slightly larger impact. But the endpoints of this study also showed something interesting, was that all of the cardiometabolic factor markers, like for example, cholesterol parameters, diabetes goals, they got better no matter what, whether they were on hormone therapy or not. So just, if hormone therapy isn't the right choice for you, it doesn't mean that you can't still improve, your metabolic health in general with weight management. So what I'd love to do is switch to the Q&A, but before I do that, I just want to give you some brief overview and some take-home messages, because this was a lot of information that I enthusiastically presented to you as fast as I could. So reminder that all hormones are human hormones, but women should be looked at uniquely with a different lens, because women are not small men, and postmenopausal women are not the same as premenopausal women, right? And hormone therapy is FDA approved for 4 reasons. Like we said, hot flashes, genitourinary syndrome of menopause. That's that constellation of signs or symptoms that happen with changes related to the vagina, the vulva, the bladder, the clitoris, etc. Premature ovarian insufficiency or premature menopause, and also the prevention of osteoporosis. But we know that off-label indications for hormone therapy at midlife might improve your metabolic health. And not just that, but maybe they make you sleep better. Maybe you have, less likelihood of getting diabetes. Maybe you have less weight gain. Maybe your lean body mass stays higher. Maybe you have less joint pain, so you're able to exercise more. Lots of off-label things to think about. And in general, hormone therapy is safe and it's affordable, and it's FDA approved for a reason, because we know it's effective. And there are both synthetic and bioidentical FDA approved medications that you can use as, orally, like pills, for example, but you can also use topically, like, creams or gels or transdermal patches. And they can be used long-term. And believe it or not, most women are candidates to take hormone therapy. So that being said, the decision to start hormone therapy obviously requires a discussion with your healthcare clinician to talk about the risks and the benefits. So that's me. So come see me at knownwell. I'll talk to you about all sorts of stuff, like perimenopause and menopause, but also your metabolic health and your goals with your weight management, with or without using hormones. And if you choose hormone therapy, we can talk about ways that it might benefit you, and the safety of it, and the side effects, and the affordability. So thank you for letting me, take that time to geek out and explain some groundwork with you. In the meantime, if you're looking for some extra homework or you're interested in this book, The Menopause Brain, wow, what a game changer when it really explores the neurodegenerative changes that can happen in women at midlife, and, explaining how estrogen affects the brain is really interesting. So I'm going to stop sharing my screen now, and let's get to the Q&A.
Thank you so much, Katelin. That was a wonderful presentation.
I do, Britta. I stayed in my time parameters.
You really did. You really did. And I'm just going to kick it off with a question, because
Let's do it.
check the box, sign me up. I'm coming to see you.
I know. I feel the same way.
But tell me. I'm curious to know. So potentially we're all candidates for hormone therapy. Why wouldn't I be prescribed hormone therapy? What is that balance, check and balance, that you have to go through when you're talking with the patient? So for instance, my mom had breast cancer. Am I a candidate to take hormone therapy?
Yeah, I love that question. And I think that, it's always a risk assessment for every individual patient, pardon. But in general, I can reassure you that there are no family history conditions, including breast cancer, that's going to stop a patient from choosing to start hormone therapy, even with family history of breast cancer. So I think that if we take the stress of your family history out of it, when I look at a woman, I'm usually looking for contraindications that might be related to serious effects on hormone therapy, like blood clots or cardiovascular risk. So hormone therapy is not a good idea for someone who's already got a history of heart attack or stroke, or you can argue maybe increased, risk for that. Hormone therapy is not a candidate, not appropriate for someone at this time who has either a history of breast cancer or a suspected breast cancer or is actively being treated for breast cancer. I want to just make a quick little caveat to that and say that a lot of those recommendations are coming from the Women's Health Initiative, or the WHI, which was the largest randomized control trial when we explored the effect of hormone therapy on women and whether or not it would reduce the risk of cardiovascular disease. And the WHI kind of shook things up because back in the early 2000s, overnight, it seemed like the opinion on hormone therapy changed because the WHI was stopped early because women were developing, serious concerns and side effects during it, which included breast cancer. We can really talk about in a lot of depth about how the WHI has been looked at many times and, reevaluated. And there was a lot of flaws with the way that the WHI was set up. So unfortunately, all of estrogen formulations, whether it's a cream or a pill, they all got slapped with the same, FDA black box warnings on them, even though we know that there's really very little reasons why a woman couldn't use a vaginal estrogen, even if she has, all these other spooky things like a history of, a blood clot, for example, or a history of a heart attack. And we can mitigate a lot of that risk by choosing a transdermal option of estrogen, which bypasses that metabolism through the liver, where you get increased risk for things like clotting issues or, other changes like that. So my overall answer is most women are candidates. There are certain absolute no-nos, and the biggest one that most women will refer to is a personal history of breast cancer or suspected breast cancer, but there is no family history contraindication. It's a lot of information.
And I think you answered about 5 of the questions in that section, so that was wonderful.
Oh, good.
And another question as it relates is, once you start hormone therapy, are you on it for the rest of your life?
Oh, I love that question. That question gets me really excited. Sure, yes, possibly. And I have a few reasons for that, right? There's no hard recommendation that women need to stop hormone therapy at any age. We can always pause and reevaluate the purpose of the treatment, and is it working, and are they having side effects? But there's not going to be a magical moment where my postmenopausal woman wakes up and all of a sudden her ovaries are working again. So when I treat a postmenopausal woman and I'm thinking of her longevity and her health over the rest of her life, I want her to stay on hormone therapy as long as it makes sense for her, especially when we're talking about something like genitourinary syndrome of menopause, or GSM, which is that constellation of progressive symptoms related to vaginal dryness or vaginal pain, or atrophy, meaning the tissue actually shrinks and goes away in your vulva. These are really serious things. And if I can help a woman prevent even one urinary tract infection as she ages, that might be life-saving right there. So for some answers like vaginal or topical estrogen, oh my gosh, I want you to be 99 and putting that on. But for oral hormone therapy, there's no hard answer if you need to stop hormone therapy. You can safely continue it long-term to continue to reduce those risks like we talked about in an off-label manner.
Wonderful. And once you are on a hormone therapy, do you need to have hormone levels checked?
I love that question too. That's an easy one. No. But a longer explanation is the goal of therapy with hormones is not a blood level. Like when we're talking about thyroid hormones, that's an easy answer. I can say, yes, I have this narrow little range of a blood test that I want your thyroid hormone to be in. There are no perfect levels of hormone therapy, especially when it comes to estrogen monitoring going forward. It's based on your symptoms. And the goal of hormone therapy is to achieve like 75 to 80% symptom improvement while also, balancing the side effects that might occur with it. So no, there's no blood work, especially in a postmenopausal woman, that's needed before you start or while you take it, because it's based on your symptoms.
That's great. And one of our participants asks, would recurring symptoms of UTIs fall in the lines of menopause when test results are not positive for a UTI? And I think you
Yes.
answered the question.
Oh my gosh, yes. If I could just even take like 10 minutes out of the time of every PCP there is and just educate them that when a woman wakes up and she turns 50, she should be given a tube of vaginal estrogen, because as a reminder, when you think of the anatomy down there in our pelvis, the bladder and the vagina, they share a wall, right? So if we're treating a woman for genitourinary syndrome of menopause with vaginal or local estrogen, it is improving her bladder. And the lower urinary tract symptoms that come with genitourinary syndrome of menopause can make women feel like they have a UTI when there's no bacteria present. So that's urinary frequency, that's nighttime symptoms, disrupting your sleep, leading to weight gain, all these things. Again, we practice medicine on a person, not on a problem, right? So it's all interconnected. But yes, absolutely. Recurrent urinary tract infections that really are due to bacteria, or just symptoms of recurrent urinary tract infections when there's no bacteria present, might both benefit from the addition of long-term hormone therapy, just to replace and repair that tissue down there that gets so starved for estrogen. So that's the answer is yes.
Wonderful, wonderful. And let's switch gears a little bit and talk a little bit more about treatments of metabolic health conditions as it relates to menopausal symptoms. And are there any studies that show symptoms of menopause improving with a certain percentage of weight reduction with some of these new therapies, or into women being able to get off hormone therapy because
Because they
of
achieve
weight?
weight loss. Yeah,
Correct.
it's a great question. So I think I'm going to answer that in two parts. My first thought is, well, why does someone want to stop hormone therapy? That'd be my first thought. My first thought would be, oh my dear, hormone therapy is so amazing. And when these ovaries age, faster than the rest of the body because we've done amazing things like antibiotics and vaccines and hospitals and good surgery with good lighting, like all these things have prolonged the human life. It's just the ovaries are lagging behind and aging like 2 times faster than the rest of the body. So if I can slow down ovarian aging, then in theory, if I continue to give you hormones, you're going to continue to live the rest of your life with less disease in general. So my first thought is, I don't really know if I'm encouraging someone to stop their hormone therapy. Just like when I have a person who I'm helping with their metabolic health and I have them on medicine for weight management, when they achieve that weight loss goal or they're feeling great and they're in maintenance, I don't recommend they stop their medicine either, because obesity is a chronic progressive disease that when you stop the treatment for it is still a chronic progressive disease that we're no longer managing and kind of comes out of remission and becomes active again. So with that in mind too, I wouldn't necessarily recommend someone stop their weight management medicine when they achieve a weight loss goal. But let's say, someone had a side effect, or they're on, I don't know, they're on hormone therapy and they have the reason that they want to stop it. I think that if we can see significant, like enough weight loss, like we had talked about, maybe that 10-pound or that 5-kilogram goal, things like hot flashes will improve. But I'm not sure. Certainly, genitourinary syndrome of menopause is something that gets progressively worse over time. The risk of osteoporosis, I think, I can't think of why that would be something that you'd want to stop treating. So no, I don't know how to answer that question. I think in general, if I were to start a person on a medicine, it's done with the idea that it's for long term. A lot of the signs and symptoms that we experience at menopause, they do get better naturally as that tissue remodels. So some of the things that women are concerned with, like the migratory joint pains, the brain fog or the cognitive symptoms, the hot flashes, those all do get better with time as your tissue gets used to the idea of that it's not going to be bound to estrogen and behave in a certain way. Even though it's getting better over time, it doesn't mean you have to suffer in the meantime, though. Does that answer your question?
Absolutely. I
Okay.
hope that answers the question. I
Yeah.
think it did.
Okay.
What would you do in the situation where someone is on hormone therapy, yet all of those symptoms, increasing midline, brain fog, night sweats, are continuing?
Mm.
What what happens at that point?
Yeah, I love that question because that's one of the things that I feel really confident in because we have so many different forms of hormone therapy, right? So if I have a woman who's got really bad vaginal dryness or painful intercourse and vulvar issues or lower urinary tract issues, and she's not responding to local estrogen, which is the preferred first line intervention, then we can increase it to a more systemic option like transdermal estrogen. Or if I have a woman with hot flashes and she's on a transdermal estrogen and she's just not hitting that 75 to 80% improvement, then maybe we can switch to an oral estrogen. Or maybe she's already on an oral estrogen and she's still not getting improvement. Maybe we need to augment the dose or play with that a bit. And we also have a wonderful bucket of hormonal intervention for other signs and symptoms that I'm sure patients have been counseled on by their primary care team, whether it's for their mood and they use, medications like SSRIs, like antidepressants, or it's for their hot flashes and they're told that they should take something else off label for them. So we've got a really nice toolbox. You just kind of need someone to coach you through it. And it's always a risk assessment, like what am I really trying to improve here? And am I willing to accept the side effects or in favor of the benefits?
Great. And what do you think about bioidentical hormones?
Oh, I
What
love that
are
question.
bioidentical
I know,
hormones?
right? Well, a marketing term. So, bioidentical is a way of describing a hormone that's not synthetic, right? And part of the fear of this is, kind of, valid, right? Because when the Women's Health Initiative, that large randomized controlled trial, said that there are side effects associated with hormone use, as we've gone back and reinterpreted this study, we're able to see that a lot of the issues were with the type of synthetic progesterone that was given to women in that trial. There were many other flaws to the study, but that's really one of the pieces of it. So no one's really using that synthetic progesterone anymore. The standard of care is to use a bioidentical, meaning, similar to or identical to the progesterone that a woman makes naturally. That's called micronized progesterone. And it's really affordable. It's like about $10 a prescription, and it's, safe and FDA approved. And I think when people are thinking about bioidentical hormones, it's because they've probably seen like a social media feed that tells them they should go and get their personalized hormone, medication from a compounding pharmacy. And that always makes me feel anxious about that because when you utilize a compounding pharmacy, they're not monitored the same way that FDA approved medications are. So right off the bat, I can't promise you that what is inside that capsule or that liquid that you're taking is actually what they say it is. And if it is actually what they're saying it is, I can't tell you that it hasn't been contaminated or that there's an issue with the safety of it. And then if it hasn't been contaminated, I can't tell you that in that capsule, you're going to have the same amount of therapeutic medicine as in your next capsule or in the next vial of liquid that you get. So there's just a lot of like kind of unnecessary variables when it comes to choosing a compounded formula of a medicine when we've got lots of safe bioidentical options that you can choose that are FDA approved. So does that help? Yeah.
Absolutely. Understanding the different terms and mixing
Yeah.
bioidentical with compounding. I think there's a lot of mixed messages out there. So it gets really
Yeah.
confusing and
Especially
overwhelming.
when it comes to like managing obesity or weight management too. I mean, if you have not seen an ad for a Groupon for semaglutide pop up, like how spooky is that? I mean, I can't even with that. But same thing. So it's the same mindset where compounded pharmacies really need to be vetted and approached cautiously. And if I can, I always make a recommendation to use an FDA approved option first. There are some circumstances where it's very reasonable to use a compounded version of something. A quick example is a woman who has a peanut allergy, right? If she takes micronized progesterone, she should really use a compounded micronized progesterone because of the way that they make it with the exposure to the peanut oil. So there are times when I do recommend it, but for the average person, there are plenty of safe FDA approved versions of bioidentical hormones.
Great. And let's switch gears a little bit from pharmaceuticals and medications, and
Mhm.
let's just talk about lifestyle. And
Yeah.
what is some of the guidance that you share with women, and what changes they can make in their diet and maybe with their activity levels that could help mitigate some of these changes in menopause
Oh my gosh,
and
I love that.
perimenopause?
Yes, right. So I'd love to start talking about physical activity first, because I think there's a lot of misconception about what exercise is and what you need to do in order for it to be considered exercise. So there's a lot of emphasis on, at least historically, on cardio or aerobic exercise being like, the best and the only way to exercise, and very little, emphasis on resistance training or muscle building, especially for women, right? And I would love to really switch the focus on that, because as I mentioned earlier in the presentation, when I think about the overall energy expenditure, that means how many calories that a human burns in a day, being a machine. The majority of that energy expenditure is coming from your basal metabolic rate, which is your resting metabolism. And the biggest predictor of how quick your resting metabolism is really your lean body mass. And that's really important to understand, because that's one of the things that's shifting at midlife. When you're not having that consistent estrogen binding to your skeletal muscle, you're not retaining your muscle mass like you were before. So not only are you having a reduction in your muscle mass, but you're unfortunately increasing your adipose storage too. So you're getting this imbalance of fat and muscle. So one of the most important things I think women of any age, but particularly at perimenopause or menopause, can do is start to build their muscle mass up. And that's with a focus on resistance training. And that seems, kind of counterintuitive to what you might have been told before, either for weight loss goals or for just your health in general. There's plenty of benefits to cardiovascular exercise too. But when I think about the biggest bang for your buck, especially as a menopausal or postmenopausal woman, and thinking about those buckets of risk, especially frailty, I think of increasing your lean muscle mass. And the way that we do that is by resistance training. So that means, yeah, lifting weights, using resistance bands, using your own body weight. You don't have to go to a gym, and you don't need to be like super confident and, feel like you know exactly what you're doing. There's plenty of resources that I kind of guide my patients to, whether they're online resources or like, fitness communities that you can join, that you can stream even from home. You don't need, lots of equipment. And honestly, in my opinion, one of the biggest changes and exciting things that I see with my patients is when they really tap into their strength training. Because I love to remind my patients that we're about gaining health here, not about losing weight. And one of the easiest ways to see gains in your health is to watch your strength go up. And a woman can build muscle at any age, at any time in her life. You don't have to be a premenopausal woman. So I think that's really important that we shine the spotlight on resistance training. But I would be doing all women a disservice if I said you can just pump iron and not change your style of eating. So when it comes to your style of eating, we know that the Lego, the building block to muscles, is protein. So everyone's probably sick of hearing us talk about protein here at knownwell, but it's so important, not just from a metabolic health lens, but also to make sure that it's there so you can build up your lean muscle mass. We have wonderful nutritionists that we work with that help our patients really target their unique protein goals, which might be based on their height to weight ratios or their kidney function or other, conditions they might have. But in general, it's safe to say that a rule of thumb is that about 100 grams of protein per day is a nice target for, an adult. And then you don't want to take 100 grams all at once. You want to divide those up in doses throughout the day. So about 20 to 30 grams of protein per meal makes sense for a reasonable target. There's also an increased risk for women of developing insulin resistance and type 2 diabetes at midlife. That was when I commented earlier about increased gluconeogenesis, or making glucose from other non-carbohydrate sources, and knowing that unfortunately, if you were someone who had insulin resistance earlier in life, or gestational diabetes, or you have a long family history of diabetes, or you had polycystic ovarian syndrome, those kind of things don't go away. They remain risk factors for you. So I would also caution women at midlife that you might be more sensitive to carbohydrates than you were as a premenopausal woman. And if that low carb diet worked for you well in your 20s or 30s, but it's not working as great now in your 40s or 50s, we might need to look more at your macronutrient, your intake of protein instead of carbs, and making sure you're spacing it out and timing it the right way with your resistance training. That was a lot of information, but I get really jazzed about it.
Important information. And I couldn't agree more with the strength training.
Oh
There's
my
a
gosh, right?
power that comes with starting to achieve just little incremental goals. Maybe you start with
Yes.
3-pound dumbbells, or 1-pound dumbbells, or no dumbbells at all.
Yes, our
And
arms weigh something.
yes. Or
Yeah.
maybe it's a milk jug or
Yeah,
a grocery
exactly.
bag. I mean, we can get really creative. But
Yeah.
it has an enormous effect on all
Mhm.
that you spoke of.
And I think two other things to comment on. One is that your exercise does not need to be something formal, right? So when we think of exercise, one of the barriers that I hear over and over again is, I don't have the time. I can't carve out 60 minutes. I don't have, the luxury of joining a gym. And I would remind my patients that when we talk about your nutrition, we talk about meals and snacks, right? So things that are planned and things that are more on the run or opportunistic or based on convenience. The same thing with exercise. You can make the same analogy with exercise snacks instead of a formal workout. So if you're someone who's, like, you can't carve out the time to have 30 minutes to dedicate to moving your body, even if you start to pepper in little tiny exercise snacks. So maybe you're someone like me who spends a lot of time remotely working from home. Maybe you have, like, in between, your calls, you can do a few squats or a few wall push-ups, or while your coffee's brewing, maybe you're doing some lunges in your kitchen. All these steps do, and all these, like, movements you make do add up over time, to create a big effect. And I think it's also really important to remind women that that number on the scale tells us very little about your health. And if you're achieving goals with, not just losing weight, but gaining health, like I mentioned. So at knownwell, one of the cool options that we have for our patients, if they can get down to our Needham practice, is to do a body composition analysis by using a bioimpedance scale that tells us not just what your weight is, but the distribution of your body tissue, like how much of it is weight related to fat or weight related to muscle, and where is it distributed? Is it in your midsection? Is it in your extremities? And that's another really cool option that we have for our patients here when we see them gain health is, the scale might have plateaued, but you built lean muscle, and that's great. That's gaining health even without seeing the scale change at home.
Yeah, and maybe
Okay.
for a lot of our listeners too, that distribution has changed as well
Yes,
over time,
exactly.
and being able to
Yes.
see those non-scale victories.
Yep, absolutely. Yeah.
That's wonderful. So, Caitlin, big question for you. Why
Ready.
has my PCP never mentioned any of this?
No, because I was a PCP for a really long time.
Me
And, like,
too. Me
I know,
too.
Britta. And I'm like, I was a great PCP. But here, I think what it comes down to is this is not a part of the standard curriculum in whatever schooling your healthcare provider has gone through, whether you're an MD or a DO or an NP or a PA. This is really something that you have to like pursue this on your own. And it's not that your PCP, like, doesn't care about you, or they're not seeing you as a whole person, or they're trying to withhold some sort of secret knowledge that they think is going to help you. Not only have they not been trained in it, But there, back in like the early 2000s, like I said, the idea of using hormone therapy was kind of spooky after that WHI, that Women's Health Initiative, came to light. So a lot of physicians in their training were taught, no, we don't use hormones. And I think that without being up to date on the knowledge that's coming out and looking at these societies, places like the Menopause Society, where I'm a member of, that's where you can really advocate for yourself. So if you're a patient and you're having these discussions with your PCP and you feel like they're not going anywhere, get a second opinion. You can log right onto the Menopause Society and you can search, find a menopause practitioner and type in your zip code, and someone like me might pop up. So I want to just encourage my patients to just advocate for yourself. And I want to if you hear anything from me after this rambling I've been doing for the last hour, it's that I see you, and I'm validating you. And whether you want to come see someone like Britta or me for, weight management or, metabolic health management, like diabetes treatment or cholesterol treatment, talking about hormone therapy is a very reasonable discussion to have. And I wish the average primary care thought about this just like they think about cholesterol medicine or blood pressure medicine. But it takes really loud, annoying people like me to keep shouting this message so that it can be a normalized conversation. And I need to wear Barbie pink to, promote it.
You absolutely do. And I need to just wear my pink earbuds that keep
Yeah, there
falling
you
out of my
go.
ears.
Hang on, let me have a quick sip of my water here.
So I know we're down to a couple of minutes, and I think it would be what's next? I mean, how do our participants get more information? Are there some, you mentioned the Menopause Society. What are some other resources where they can go? And will we hear from you again? That is the
I
question.
I would love to. I
I
have a
think we have a
lot.
lot. I think we have a lot to share.
Yeah, like I said, Britta, thank you for helping me cut down my PowerPoint by like 100 slides. So I would love to continue to offer, these kind of sessions with the Q&As so you can get a chance to really, ask your question in a safe space. But you can find me at knownwell, and you can find my menopause clinician colleagues by going on the Menopause Society. Maybe what we can do is we can update some links in like the program notes, or we can send out like kind of an email blast too for anyone who's looking for further information. There's also some amazing menopause experts that are being very vocal and sharing their story on free platforms through their podcasts. Think like, for example, and I can give you these links too, but there's two really amazing physicians. One is Dr. Lauren Stryker, the other is Dr. Kelly Casperson, just wonderful advocates for women who have a really strong voice. And yeah, things are going to get better. There's more research, there's more interest in women's health, and this is it. This is a really exciting time.
We need to keep talking about it and
Yeah.
sharing, and you talking with your friends and your family, and
Mhm.
it's such an important message, and so much content to learn and
Oh
understand.
my gosh.
So
Yeah.
there are a few questions we did not get to, and we'll try to send something out to the participants with the resources, but really appreciate your attendance tonight. Really
Yay.
fun
Thank you,
to be a part of
everyone.
it. Thank
Thank
you.
you. All right. Thanks, Britta.
Yep. Bye-bye.